Well, praise the Lord, everyone. Let me take this opportunity welcoming all of you to this meeting. I see Pastor McDonald, and I can see Elder Neil. God bless you. Welcome. Yes, I welcome you to this very important overview on this diabetes meeting. I'm thankful to have with us today Sister Carol, or Dr. Carol, and Sister Elaine. Praise God. We thank God for the both of you. A few weeks ago, I was in a discussion with a group of people. And in that discussion, the subject diabetes came up. And it was from that discussion I realized just how little a lot of us know about this devastating illness. I know of people who have lost their limbs and people who have, lost their visions through this illness. So yes, it is a devastating illness. And that is why I asked Dr. Carol if she would give a talk on this important subject. So as we listen to our speakers today, I am sure that we'll gain a better understanding on this subject. And I'm sure also that you don't want to hear me make a speech. So I'll hand back to our moderator, Brother Simon.
Praise the Lord. Amen. They say that information is power. Amen. And that we're not going to be aware of anything if we do not know. So we give God thanks that we're going to be enriched by the knowledge by our two speakers. I'm not going to speak for long because I must speak about our first speaker, who is Sister Carol. Amen. Dr. Carol S. Igafos, who is a mother, general practitioner, author, company director of LidiMed Limited, a professional speaker and a missionary, and she also serves as the lead for the Bethel Central Wellbeing Team. Dr. Carol has worked in a range of primary and secondary care settings over the 30 years spanning her professional career. As it relates to her experience with diabetes mellitus, she has worked as an academic junior doctor with the renowned Diabetics and Cardiovascular Research Team at the University of Leicester, assisting with systematic review and meta-analysis, and co-authored a published report on CVD screening program during her time with the team. She has worked on a specialist diabetes ward and in diabetes outpatient department, and is still involved with managing patients with diabetes in her current role as a sessional GP in Leicester. In her capacity as a medical doctor, as well as a patient currently navigating the health system, she is a unique authority on health matters. Following a heart attack about 3 years ago, she has been an ardent supporter of the British Heart Foundation and has been nominated and made it onto the finals list of the British Heart Foundation Heart Heroes 2021. The final ceremony to be held on World Heart Day, 29th of October 2021. She is asking everyone, please spare a thought and do something to protect yours and someone else's heart on that day and every day, and lend your support to the British Heart Foundation in whatever way you can. So without further ado, I hand over to Sister Carol in Jesus' name.
Thank you very much, Father Simon. And I'm so glad to see everybody here today. Welcome, everyone. Welcome all. So without further ado, I'll start sharing my screen and go straight into the presentation. But just to say that just by being here today, that's doing something good for your heart, because you'll find out that there's a very, very close link between diabetes and our heart. Okay, can you see my screen? Can everybody see my screen?
Yes, Sister Carol.
Yes, thank
Thank
Yeah,
you.
can
Oh,
see it.
I hear Sister Nadine in the background there.
Morning,
Welcome.
everybody.
Okay, so today we're talking about diabetes mellitus, and I'll be using the letters DM for that as a short form of that. And I'll just be doing an overview because it's a vast subject. I have specifically mentioned the word mellitus because diabetes we just use as a short form of the word, but there's also another condition called diabetes insipidus, which is a totally different condition. So diabetes means excessive production of urine. It refers to a siphon producing a lot. And the word mellitus means sweet. So this is sweet urine, whereas the other condition is insipid urine. Believe it or not, in the past, doctors had to taste the patient's urine to make this diagnosis. So it is diabetes mellitus that we'll be talking about today. So at the end of my talk, I'm hoping that you will be able to, if not word for word, but have an idea of what the definition of diabetes mellitus is. Understand the pathophysiology, and that's a big word for saying understand what goes wrong in the body when we get diabetes mellitus. Have an idea of what the risk factors are and how it is diagnosed, how the condition is diagnosed, and also have an idea of how the condition is managed and the complications that can occur, and as it relates to going into the future, what is it that we could look forward to in this condition. So for definition, diabetes mellitus is a group of metabolic disorders in which persistent hyperglycemia, and persistent hyperglycemia meant persistent high gly means glucose, cemia means body. So persistent levels of high, we say sugar, but it's specifically glucose in the blood. And it is caused by a deficient insulin secretion or resistance to the action of insulin, or both. So note these two things: deficient insulin secretion, resistance to the action of insulin, or both. And the insulin deficiency and insulin resistance lead to abnormalities of the carbohydrate, fat, and protein. That's the main nutrients in the food that we eat, how it's metabolized, how it's broken up in the body. And that is what is characteristic of diabetes. So in terms of diabetes, there are several classifications that are used to classify diabetes mellitus. I'm going to be looking at the two main broad classifications today, and that is diabetes mellitus type 1. So we call it type 1 diabetes, and I'll be using the shortened version, T1 DM, to mean type 1 diabetes. And then the other one is type 2 diabetes. However, it is worth you being aware that there are other forms of diabetes. So there is gestational diabetes and other types of diabetes occurring, for example, monogenic diabetes, which is where there's a specific gene problem that is inherited from a parent. And that's a specific type of diabetes. And there is also diabetes that you can get from problems with the pancreas. So if you've had surgery to the pancreas, if you've got malignancy, cancer of the pancreas, that might cause you to end up with diabetes. Some endocrine disorders can also result in you having diabetes. And some drugs, for example, steroids, if you're on steroids, that's one drug that you could end up having diabetes. And chemicals like alcohol damaging your pancreas can cause you to end up with diabetes. And there is a term that is pre-diabetes, and that is a terminology that I want us to bear in mind. It is not a classification as such, but it is recognized as a condition. So when you've got this condition, you're at very high risk of developing diabetes. We'll talk a little bit more. Some people refer to it as by different names, but it is generally called pre-diabetes or which means you're at very high risk of diabetes. Just to go back quickly to type 1 and type 2 diabetes, I just want to make a clear distinction. In terms of type 1 diabetes, the main problem here is an absolute insulin deficiency. So in type 1 diabetes, there is insulin deficiency. There's no insulin being produced in the body. These people will die within days or weeks if they do not get insulin. In type 2 diabetes, there's insulin being produced, but there is resistance to the insulin being produced. So just to make that clarification, it is important that we are aware of that clarification. So I just want to make that very clear. So in terms of the pathophysiology, what goes wrong when we have or when somebody has diabetes? I've mentioned the pancreas. The pancreas is the main organ that is involved when we talk about diabetes mellitus. So I don't know if anybody remember the pancreas. When I was growing up, I think we used to call it sweetbread, but probably people call other things sweetbread. But it is up in the upper part of your abdomen, towards the back, towards the left. There's a picture here of it. And now in the pancreas, for those of us who did biology at school, you might remember that there are some, what are called islets of Langerhans. Nowadays, they refer to them mostly as pancreatic islets. But if you can see these little blue things, they are little islands, as it were, that are dotted throughout the body of the pancreas. And these are the parts of the pancreas that produce insulin. They also produce another hormone called glucagon, which is important in maintaining blood glucose level in the body. So in the pancreas, as you can see, produce other hormones. The pancreas is described as an endocrine organ because the insulin and the glucagon that it produces goes straight into the bloodstream, as you can see, it's going straight into the blood vessel here. But it produces other hormones as well that are, should I say, other enzymes that are used in the process of digestion. For example, trypsin in protein digestion, lipase for fat breakdown, etc. So it has other bits, and that's called the exocrine function of the pancreas. But what we're concerned about is the endocrine function of the pancreas. So that's the function of it producing the hormone insulin and glucagon, which goes straight into the blood. So insulin is produced in these little blue islets, the pancreatic islets, when there is a raised level of glucose in the body. And the level of glucose is raised in the body when we eat. So we've had a big meal, our glucose level is raised. Our body is made up as such, so wonderfully made up, that our glucose level is meant to be maintained between about 3.8 or up to about 6 point something. So under 7, generally speaking. And if your body is working okay, if there's no problem, the blood glucose level will remain at that because of the action of insulin and glucagon. There's a process that goes on that maintains it. So if you're not diabetic, even if you're hungry, the body will break down what is stored and your blood glucose level will be maintained in that steady state. We call it glycemia homeostasis. So it is mentioned, homeo means same and stasis same and state. So it will be maintained at that level regardless of until you've eaten, or unless you take a really, really long time to eat. So generally that's what should happen. So the insulin and when the blood glucose is raised, insulin will be produced. And what the insulin does, it will cause the body, it will act on the cells of the body. So the cells in the various parts of the body, the muscle cells, the brain cells, all the cells in the body. And there are some receptors on each cell that are insulin receptors. So the insulin will lock into these receptors, and that receptor will send a message to the inside of the cell and tell the cell that it needs to bring something to the surface of the cell that we call glucose transport. that glucose transporter will come to the surface of the cell, and it will take the insulin from the blood into the cell, and then that will cause the insulin will allow for the glucose in the blood to be transported into the cell. So the insulin is acting like a key to allow the glucose to come out of the circulating blood and go into the cell. It needs to go into the cell because our cell needs to use this glucose to produce energy. There is reaction that goes on in the cell. If not, we'll become very lethargic, very tired. If the glucose cannot get from the blood into the cell. I hope that's making sense. So that's one way that the body maintains a normal level of glucose in the body. The other way is that we might not use all the glucose that we've used from the meal or whatever meal we eat. What the insulin also does is it converts the molecules of glucose in the blood to one long chain. So it kind of packs it together into something that's called glycogen. And glycogen will be stored in our muscles and in our liver for when we need it. For example, when we're fasting, as I said, it will break it back down by the action of glucagon, and that will maintain. So there's a whole cycle going on. So we need insulin to maintain our blood glucose level. Insulin responds to a high glucose level by getting the glucose into the cell or converting the glucose molecules to glycogen, which is then stored into the body. I hope that makes sense. So that's the action of insulin. Now, when there is diabetes, either there is no insulin or the insulin that is producing is not responding to the receptors on the body cells. And that's pretty much what happens in type 2 diabetes. So the glucose can't get out of the blood to go into the cell, and that causes a problem. So what causes type 1 diabetes? Like I said, I'm doing an overview, so just quickly talking about type 1 and type 2. As I mentioned, in type 1 diabetes, there is a problem with insulin production, and that is because the islets of Langerhans, those pancreatic islets that I've just showed you, these blue ones, in type 1 diabetes, the body has turned against itself and has damaged all of these. It's an autoimmune condition. Our body's immune system is meant to fight bacteria and viruses, but there is the mistake of sort, and autoimmunity occurs where the body breaks down, damages all of these. And as a result, the body cannot produce insulin. So people with type 1 diabetes, that's what has happened. That's something that's in the genes, it's passed on from in families. And also there are thought that there are environmental factors that trigger this as well. So even if somebody has that gene, and there are certain environmental factors that can cause the autoimmune destruction of the islet cells to occur more earlier. For example, the environment that you live in, the pollutants in the air, your exposure to certain viruses as a child, stress-related factors, all of those environmental things can also cause it. So for type 1 diabetes, it's either genetic or environmental cause. And if you're type 1 diabetes, you would know, because when you're diagnosed, you're usually told, and you would most likely, there would be somebody in your family who has type 1 diabetes. And it's usually a diabetes that is diagnosed at a very early age. Can be from as a baby or in early adult, but generally speaking, under the age of 40, but usually very, very early. So type 2 diabetes is the diabetes that is more common. That is what most adults get. That is what is common in our Western society. And I put obesity and an inactivity at the top here as to being the risk factor, because apparently 80 to 85% of type 2 diabetes occurs as a result of being obese and inactive. So that's the main cause for type 2 diabetes. However, it is also caused by it running in individuals' family. So if, for example, in type 2, it's a different process from type 1. In type 1, it's a genetic dysfunction. In type 2, also genetic function, but a different method, a different way of working. So, for example, in type 2, if your one parent has type 2, you're apparently about 15% likely to get it. If both your parents have, you're about 75% likely to get it. So can you imagine if your parents and your brother and your sister? So basically what I'm saying is it runs in the family as well. But remember, the main cause, all of these other ones, all of these other factors here only occur for about 20% of type 2 diabetes. 80% or more is as a result of obesity and inactivity. Ethnicity is a factor that puts you more at risk. So those of us who are of Black, African or Afro-Caribbean or Asian ethnicity are more likely to get type 2 diabetes than our white counterparts. If a woman has had gestational diabetes, so diabetes in pregnancy, is more at risk of getting type 2 diabetes later on in life, even if the diabetes disappears after she's had the baby. And apparently the baby is also more at risk of getting diabetes, type 2 diabetes later on in life. Diet, obviously, as I mentioned, obesity and inactivity. So it's more a diet if we eat very processed food, white bread, white rice, white everything. We need to be eating a diet low in low processed food, so natural foods, and low in fat, low in sugar, and more natural, high in fiber. I'm sure we'll talk more about that. Some drug treatments, as I mentioned, can trigger diabetes, like if you're on steroids. Some of the drugs that I take, for example, unfortunately predispose me to getting diabetes, like the statins, but I have to make a judgment as to what best balance is, and make that decision about taking drugs. Some people have diseases like polycystic ovaries, that some women have that. If you've got that, you're more at risk of getting diabetes. Metabolic syndrome refers to a group of conditions where there is high blood pressure. There is what we call central obesity, so you carry more fat around the middle, on your waist, and there are problems with your cholesterol levels. So if you've got metabolic syndrome, then you're more at risk of getting diabetes. And apparently, if your birth weight is low, so low gestational age, so you're premature, babies usually born before 35 weeks old, apparently there is research to show that they are more likely to get type 2 diabetes later on in life. As I mentioned, environmental factors, similar to that in type 1, so stress factors, pollutants, virus exposures as a child, all of those can cause type 2 diabetes as well. So quite a few things. In terms of diagnosing diabetes, there need to be some clinical features, and I'll go to the clinical features as you can see down here. We have what we call polydipsia, polyuria, and unexplained weight loss. Those three are called the classic triad of diabetes. Polydipsia is a big word, but all it means is excessive thirst. Poly means many, dipsia. So lots of excessive thirst. Polyuria means you're passing lots of urine. And if I had time, I would explain why all of this is happening. And unexplained weight loss. So people who present with diabetes tend to have these classic three. But there are other things like blurred vision, recurrent infections, feel tired and lethargic. Because remember, the glucose can't get in your cells for the reaction to happen, for energy to be produced. So you'll be tired. So people will tell you that they're just tired all the time. And sometimes there are skin changes in the folds of the skin where it becomes very dark. And that's a condition called acanthosis nigricans. And that is a sign of diabetes. And so there has to be these clinical features, at least some of them, but usually those three classic ones are present. then there's to be the presence of the risk factors that I've just described. So somebody comes to me as a doctor, they've got these symptoms, and then I ask them, does anybody in your family have diabetes? Yes. And I look on them, probably they're overweight, and there are lots of other things. Then the risk factors are there are clinical features. Then my job is to prove that this person has diabetes. And so in doing that, I would request some blood tests. So that's how the diagnosis is made. In terms of the blood test, I'll probably check the urine there and then. And the urine probably will be, most likely will be showing that there is glucose in the urine. Glucose is not meant to be in our urine. The kidney is such that the glucose molecule is not usually passed into our urine because it's the blood reabsorbs it. But if there's diabetes and it goes over a certain threshold, then it's going to spill over into the urine. So and that is what, so you've got glycosuria as well, or glucoseuria, so glucose in the urine. But in doing the blood tests, there are 3 that we currently use a lot in the UK, specifically one called HbA1c, which it measures your blood glucose level over the last 3 months. What it does is that the sugar in the blood sticks to the red blood cells. Most red blood cells live for about 3 months in our bodies. And we can use that to measure the average level of blood glucose. So that's a good indicator. And if the level is over 6.5%, then that's diagnostic of diabetes. And I talked about pre-diabetes. If it is, I think, 6 to 6.4, that's pre-diabetes. And that is something that we wouldn't just leave. We would still be monitoring you because it means you're at very high risk of getting diabetes, which is 6.5% of the HbA1c. We can also use a fasting plasma glucose, diagnose it, and or a random plasma glucose. If somebody doesn't have symptoms, we don't just take one reading, we would repeat the bloods. But if you've got symptoms and everything else is there, the risk factors are there, the features are there, and the one blood glucose level is abnormal, then we would make the diagnosis. So having made the diagnosis as a doctor, I would be talking to you a little bit, maybe starting your drugs, but I'll be sending you to Sister Elaine to talk to you a lot about the lifestyle factors, because lifestyle factors, I would say, are probably even more important than the drugs that we will give you. It's very, very crucial. Now, for somebody who's got type 1 diabetes, they would immediately start on insulin, and otherwise they will die. But everybody needs lifestyle. So management includes lifestyle, drugs, that's what we by therapeutics, probably surgery, that's something that we can talk about. And is there a cure? Some people go into remission, and some people go as far as saying that they've been cured from diabetes. So just quickly talking about lifestyle, has to do with diet. And like I said, the main thing is about having a diet that is free from processed food, free from lots of sugars, free from lots of fats, especially saturated fats. Nowadays, the mainstay is about a low-carb diet, and you'll hear probably bandied about intermittent fasting or extended, if reduced feeding time. Sorry. So it basically talks about when you allow more, a wider window between the times you eat. So you might eat earlier in the evening, say before 8 p.m., and you might not have your breakfast again the following day until about 9, 10 or so. So it's allowed between 12 and 14 hours of fasting period between meals. We can talk a little bit more about that again in the Q&A if we've got time. Exercise, activities, that's very, very important. And activity means not sitting down for too long. Even every hour, get up, go do something. If you're watching TV, you can be moving your body. You can stand up and do something whilst you're watching TV. So it's about movements. And for me, relaxation and relationships are very important lifestyle factors, just because lack of them means additional stress. And it's just very important in how we manage our lives and prevent illnesses generally. And getting enough sleep, something that we sometimes don't pay enough attention to. But because of our circadian rhythm, i.e. our body works, what hormones are produced at what time, how our body digests food. If we eat later at night, it hangs around longer because at that time our body is getting ready to sleep. The hormones that are meant to be digesting food are not readily available. The body is producing melatonin saying it's time to sleep. So it's not a good idea to be eating late at night. It will affect your sleep, and that's because diabetes. That's something that I myself need to take on board because I have not got very good sleeping patterns sometimes. But in terms of management, we'll be having periodic reviews or annual reviews. Again, Sister Elaine will tell us more about that. Managing your eyes, your feet, and your kidney is very important. Some people will have issues regarding driving because if you're on insulin, you have to declare that to the DVLA. And you'll find that you may be asked to monitor your own glucose levels at home, depending on the type of diabetes you've got. And there is something that we refer to as sick day rules as to how you manage yourself when you're sick and you've got diabetes. There are certain things that must be observed. I'm hoping Sister Elaine, you talk a little bit more about that as well. So in terms of the medications that we use to manage diabetes, like I said, if you've got type 1 diabetes, it's insulin. From the start, you need insulin, otherwise you will die. But for type 2 diabetes, insulin is not necessarily needed at the beginning. Most times we will start with a drug called metformin. And then there are a lot of other drugs that we add in, but usually once we've added in the second drug, insulin can be added. So you'll find somebody with type 2 diabetes, after a while, they may need to go on insulin. And then there are all these other drugs that can be added. And earlier on in my career, all we had was metformin and a sulfonylurea, maybe glycoside. But nowadays, because of studies and researches that have been done, there are lots more drugs. It's more of a dilemma, but it means that the treatment can be tailored more to individuals. So it's good in a sense, but it's more of a puzzle coming up with the correct management for patients. So surgery is sometimes done for diabetes. It's usually what we call bariatric surgery, and you qualify for it if you're obese, basically. Have a BMI of equal to over 30, lower in Asians because a lower BMI constitutes obesity for them. And that is when all other measures have been tried. Your GP will refer you. You'll have to have obviously assessment and a lot of talks done before that is agreed on. But that's something. People who've had that, apparently up to some people claim cure or say that at least they're in remission because their blood sugar level returned to normal. And it just means that you're taking a smaller amount of food, really, and people become more conscious of what they're eating and paying more attention. It cures the diabetes or at least send people in remission. And there are studies to show that at 5 years, over 50% of people who've had this surgery remains non-diabetic. However, if that's the case, you still need to have your retinal screening done, and we will still be testing you regularly, doing the HbA1c maybe every 6 months or every year, just to make sure that there is not a relapse. There are lots of complications that can occur because of diabetes. And unfortunately, it's not something that we get and everything is fine. The main complications we talk about are we class as macrovascular and microvascular diseases. So basically, diabetes, which means, like I said, a persistent high level of glucose in the blood affects the blood vessels. And because of the effect that it has on the large blood vessels, like our arteries, and the small blood vessels, like the ones in the back of our eyes or in our kidneys, they are referred to as macrovascular, large blood vessels and microvascular diseases. And that results in things like ischemic heart disease, which causes heart attacks or stroke. So the brain and blood vessels are affected. The blood vessels in our legs, the peripheral arteries, so we end up with amputations. And it can cause people to die suddenly because of these conditions, whether you die suddenly from a cardiac arrest or you just die suddenly. And most people, though, with diabetes die from cardiovascular diseases. Occasionally, or sometimes, you can die from complications like from a diabetic ketoacidosis, coma, or hypoglycemia. But most people who die from diabetes is as a result of cardiovascular disease. So it's worth bearing that in mind. Hence, I was saying the link between the heart and diabetes. So complications carrying on with that, it affects your kidney. You can end up with chronic kidney disease, end-stage renal failure, end up on dialysis or requiring a transplant. It affects the eyes and get glaucoma, cataract, special diabetes, what we call diabetic retinopathy, which affect the retina at the back. And this can lead to visual impairment or blindness. It can also affect the nerves in your skin, either because the high blood glucose level damages the nerves in the skin, or it means that the blood vessels that supply the nerves do not get enough blood, and this causes damage to the nerves. This can cause significant pain. I had a patient today that had to go into hospital via the ambulance because of diabetic neuropathy. He graded his pain as 10 out of 10. So it can be very painful, or you can end up with ulcers because you might have a little something, maybe a little stone, a little gravel in your shoe, and you don't realize you end up with an ulcer, and you could end up with amputation. And it also causes problems with the autonomic nervous system. So you might find that you faint easily, your blood pressure drops easily, and you sweat a lot, and some other strange things happen because of this. It affects our sexual function. So for men, there is erectile dysfunction that can occur. That has as a result of the microvascular and the neuropathy. So it's a combination of things. And women are also found to have sexual dysfunction because of diabetes. It affects our lipids in our blood. So instead of having normal cholesterol, a high level of good cholesterol, which we call HDL, you'll find that there are lots of triglycerides and bad cholesterol. Psychological effects occur as a result of having diabetes. People are more prone to getting depression and anxiety, and something that they specifically refer to as a diabetes psychological problem. Young people who have type 1 diabetes suffer a lot because they feel left out. They have to take insulin at certain time, and insulin causes people to put on weight. So some people have omitted their insulin in order to not put on weight. And there's this term that has been coined that's called diabulimia. It's not a proper medical diagnosis, but basically it refers to when people omit their insulin in an effort to lose weight. It's an eating disorder of sort. And that is obviously a risk-taking behavior, and you could probably class it as deliberate self-harm. So those are all psychological effects of diabetes. And like I mentioned, as a direct result of excessive glucose in the blood, for type 1 diabetes, it's something called diabetic ketoacidosis, or in type 2 diabetes, it's hyperosmolar syndrome. I can't remember the total here. But that is something that is similar to DKA in type 1. And if your blood sugar drops very, very low because you're on insulin, which is a complication of insulin and some of the other diabetes drugs, you could end up dying, because if that happens and nobody's there to help you, you would end up dying. In terms of going forward, new drugs are coming out all the time. There is now insulin pumps and what we refer to as artificial pancreas that are available. People can now manage their blood glucose levels without having to prick themselves 10 times a day, especially type 1 diabetes patients. And also, there are now smart insulin pens and apps where you can download all your blood glucose readings and everything onto an app, and it just helps you to monitor things more. So, in conclusion, we think of things like COVID as a pandemic, but diabetes is actually a pandemic. It's a global pandemic that's officially recognized. In England, for example, at the moment, it's about 4.7 million people that is estimated to have diabetes. And by 2025, it's estimated it will go up to 5 million and 5.5 by 2030. Insulin deficiency, so remember the terms, insulin deficiency, where there's no insulin at all, and insulin resistance. Those are the two things that happen in diabetes, deficiency in type 1, resistance and/or deficiency in type 2. They are the key players in what goes wrong in the body while people develop diabetes. And it means that there's a persistent hyperglycemia. We have looked at the classification of diabetes as type 1 and type 2, but just remember that there are other classifications of diabetes, including subcategories of type 1 and type 2. There are several risk factors for diabetes, including genetic factors, familial factors, and lifestyle. So obesity and inactivity. Complications of diabetes include macrovascular and microvascular problems.
Yes, sir.
And diabetes is generally a long-term progressive illness, but it can be managed successfully with lifestyle and medications. And surgery may play a role in diabetes remission and/or cure. We'll take questions at the end of Sister Elaine's. So thank you very much.
Praise God. Thank you very much for your presentation, Sister Carol. Just a reminder that anyone with their mics, can we make sure they are muted? If I can ask Pastor if there's any that needs to be muted, if you could do so, because it's very essential that we try and keep this as streamed and calm and running as much as possible with the times that we've got. So without further ado, I'm just going to keep going with the time. I'm now going to turn over to Sister Elaine. She has over 30 years experience in the NHS. After qualifying as a general nurse, she went on to train and work as a midwife, which included working in Saudi Arabia, delivering the babies of military wives. She then went on to train and work as a health visitor, working with patients in the community from cradle to the grave. After many years and working and managing contraceptive services, she then moved into her current role in an inner city GP surgery, where she uses all her years of nursing experience to help manage the long-term health conditions and offering health screening and health protection to a population of over 9,000 patients. She worships at Bethel 393 in Manchester under the leadership of Bishop Designate David Miller, and she's a Sunday school teacher in the women's leadership team. As I turn over to Sister Elaine in Jesus' name.
Amen. God bless you. Thank you, Brother Simon. And thank you, Pastor Hunter, for allowing me to join Dr. Carol with this presentation. As Dr. Carol has said, it's a really important discussion for us to have, because I think there are so many of us, if we don't have it ourselves, we know somebody that's got diabetes. And I do actually want to just mention that just because diabetes is really common, it doesn't mean it's right. It doesn't mean that we want it. So we shouldn't take it as oh, it's just diabetes, because it can have devastating effects on us. So at this time, I'm just going to share my screen. One moment. And hopefully you'll be able to see this. Can everybody see that?
Yeah.
Yes. Yeah, thank you.
Good.
Okay. Right then. So this is just my discussion just about how the patient experiences. So from knowing that you have diabetes, when you have that diabetes, it's really important that you know how to look after yourself, because you might see us in a general practice, you might see a doctor, your nurse, literally for a few minutes per year, but you're living with this every single day of your life. So it's really important for you to know how to look after yourself. And it's great if we have people with diabetes that are expert patients. They know what they're doing. They know how to look after themselves. So this is what we're looking at. Okay, so having a review of your diabetes, it's just an opportunity to find out how you're getting on and how you're managing day by day. Because as I said, you're living with it. So we want you to be not comfortable having it, but comfortable in knowing how to manage your condition. We want to know what's working and what doesn't work for you. Because again, if you have a condition and there's something that's stopping you progressing, something that's stopping you feeling well, we want to know, and so that we can find out how to help you. We want to be able to look for signs that may indicate areas of concern. There is that saying that says we want to nip it in the bud. We don't want things to progress and you either didn't come to us, you didn't feel you could come to us, or we didn't know about it. So if you know or feel that something's not right, we want you to let us know. And so if that's the case, we can help you either to prevent or to slow down a deterioration and refer if necessary. There are lots of places and departments in the NHS that we can refer you to should you need any help. So we call it an annual review, but it isn't necessarily annual. There's a few things recently that have caused a change in how often people are seen. So as we know, we are still in a state of pandemic with coronavirus. So because of that, GP practices were literally locked down, as you know, and we were only seeing absolutely urgent cases. So that meant that a lot of people that were due for their annual reviews of all long-term conditions, it wasn't just diabetes, it was heart disease, hypertension, all sorts, smear tests, we had to stop everything. And then once we've started getting back into our hopefully more of a normal flow, there are a lot of people that have missed out on their appointments. So the only way, it's almost impossible to catch up, but the only way that I think probably Dr. Carol is doing at her practice as well, is that we're now seeing people in the month of their birth. So I was born in August, so if I had a long-term condition, asthma, whatever, if I hadn't been seen over the last 18 months, I know that last month, hopefully I would have been called to be seen to check my asthma, you to check your diabetes, you to check your high blood pressure. So if you haven't been seen in the month of your birth by the end of this year, make sure that in the month of your birth, phone up your doctor's surgery and say, I didn't get my asthma review, I didn't get my diabetes review last year, please can I book in? And that's the only way that we can really realistically try our best to catch up with all those people. Now, that would be an annual review. However, if somebody has any problems with their condition, we do tend to see you more frequently. So, for example, if you've got blood sugars that are just not staying to target, can't get them down, then we'll probably see you a little bit more frequently, just to give you a bit more input, because it's really important to get the blood sugars down. As Sister Carol has already said, that there can be quite devastating effects to your body and your organs if diabetes isn't controlled. So it's really important for us to be able to work with you to come to us, so that we can have that two-way conversation to be able to hopefully get your condition under control. So the review, the annual or other, the review happens usually in 2 stages. So the first stage would be a physical examination, and then the second stage would be after we've done certain things, we then come back and either on the telephone or face-to-face talk with you about how you got on with your physical examination. So our little first, my icon there, it isn't a high five, it is kind of a high five, but it's saying hello, but it's actually to do your height. We want to do your height, we want to do your weight, so that we can find out what your body mass index is. Now, because of coronavirus, we blame everything on COVID, but I know that myself and many other people have put weight on over in the last 18 months for various reasons. We haven't been as active, but as it is, we need to make sure that we keep our body mass index within targets. The height-weight ratio, which is the body mass index, the government or the Department of Health want it to be between 19 and 25. Now, I know that mine's a little bit over 25. However, the target is 19 to 25. And especially if you've got long-term conditions, it's a really good idea to try to aim to get your body mass index within a target range. The next one, the apple and the pear. Some of you may think, why have I got an apple and a pear? It's not talking about fruit, it's talking about waist circumference. So being an apple shape means that your greatest weight is around the middle, and this is around the main organs of your body, which can be predisposing to long-term health conditions. We would prefer it if you were more of a pear. So a lady, if you've got bigger hips and a smaller waist, that's a better shape than being an apple shape. For a man, if you turn the pear upside down and you've got the bigger shoulders, smaller waist, that's what we're looking for. And the actual waist measurements, you might say, well, what does that mean? The waist measurements, we want that men have a waist measurement of less than 37 inches, and that's 94 centimetres. That's a target to have, not to have a waist more than 37 inches. For a lady, it's 31.5 inches or 80 centimetres that is an optimal waist measurement. So that's just a target for you to work towards as well. For me to work towards as well. I'm including myself here. We also do your blood pressure as well. Now, again, because of the pandemic, we haven't been able to keep on top of monitoring as many blood pressures as we'd like. But what we're encouraging now is that if you are able to have a blood pressure machine at home, in the past it was, why do people have machines? I was one of these. Why are people having machines and they don't know what the numbers mean? You need to know your numbers. And because of cross-infection, we're trying not to use the hospital and the GP equipment as often as we used to. So if you have your own machine, please take even a weekly reading of your blood pressure. You can see on there that blood pressure is 120 over 80. That's an amazing, a lovely normal blood pressure. When somebody has diabetes, we're more strict with blood pressures and readings because we want to make sure that your readings are as close or below target as possible, especially where blood pressure is concerned. Because if you imagine, if your blood pressure is too high, it's going to put more pressure on your heart to be able to pump the blood around your body. And if it's putting more pressure on your heart, then that's predisposing you to heart conditions. So keeping all of your numbers within target is what we're looking for, and there's a reason, because if not, it can have a knock-on effect on other systems. At the end on the right there, we've got the eye. So that's actually a picture. It's not a star or a moon. That's a picture of an eye. So when you're diabetic, when somebody has diabetes, if you wear glasses, yes, you need to have your regular annual eye test. But this particular test is called the Diabetic Retinopathy test. So it's looking more deeply into the back of your eye, because diabetes can cause bleeding in the back of your eye if it's not controlled. So again, we want you to control your sugars. We want to help you to look after yourself so that you know what examinations you are entitled to every year. So that's what's on this slide here. When somebody's newly diagnosed with diabetes, certain things automatically come into place. So the diabetics eye screening, that's done externally. You'll be called for that. But the rest of the things that are on this screen are what we would do in a GP practice. So the next one is a blood test. So with the blood test, what we're looking for is your sugar level. Obviously, that's what diabetes is mostly concerned about. But we're also looking to see about health of your kidneys, the health of your liver, the thyroid, and we may also be looking at your liver, and also your B12 and folate. So that's your iron and anemia levels, because we want to make sure that your whole body is in its optimum position. We also want a urine test, because that, again, will test in the surgery, if you like, to dip for urine particularly, and for glucose, and another range of things. But also we do send that off so that it can be looked at in the labs for microproteins. because if the kidneys are not working properly, they're going to leak protein. So the kidneys, the way I describe it is the kidneys are the sieve of the body, and it sieves the blood. So imagine pouring water through a sieve. It'll go through very quickly. The sieve has no hard work to do. But imagine if that water or the blood is sugary. I imagine it's thicker, more syrupy. So it's more difficult to sieve, to get through that sieve. So the kidneys are put under more pressure trying to get the blood sieved through, to sieve out what needs sieving out and pass through what needs passing through. So this is why some people get kidney damage, because if the kidneys are overworked and overstressed trying to sieve the blood of a very highly somebody with a lot of sugar in their blood, and it does put more pressure on the kidneys. So we want to just check how your kidneys are going on. The next thing that you have annually is a foot check. Now, if you can see that little blue stick there, that piece of equipment is called a monofilament. That's a piece of equipment that we use when we're doing a foot check. But even before we do that, we look at your feet. We look at the skin. Is the skin intact? Because if the skin is broken, if you've got a cut, anywhere on your body, but especially your feet, if you have a cut, you may or may not even know about it. If a cut is open to the air, there's a higher risk of infection. And when somebody has diabetes, infections don't heal so quickly or so well. So we want to make sure that your feet, your skin is intact and in good condition, and also not too hard. Because if you look at that monofilament, it's got just a tiny little plastic fine tube. And that tube is what we use just to press certain parts of the foot and the toes to find out that you can actually feel those little, those pinpricks, if you like. Now, if that doesn't happen, it's showing that your circulation or your nerves may be damaged, and that is predisposing to what we call neuropathy. And neuropathy of the foot can be quite dangerous, because if you're walking and you can't feel, and Dr. Carol did mention this before, if you're walking and you can't feel that you've got a little stone in your shoe, or I even say to some patients, you know, when you cut your nails and some of the nail cuttings may just fall on the floor, you may not pick all of them up, but if you were to just stand on one of those and you had neuropathy, you wouldn't even feel that you'd stood on it. And so it could cut the skin. And if every day you're not washing your feet, looking at your feet, you may not realize that you've got something stuck in your foot, stuck in your skin, and that could become infected and get worse and worse before you even realize it. So it's really important to be very, very aware of the condition of your feet. When you cut your nails, don't cut them too long, because they might overgrow and start poking into other toes. They may even, if they're too long, they may squash into your shoes and so cause pressure on your toes. If they're cut too short, then you might cut the skin itself. So you want to cut them so that they're straight across, not too high, not too low, but then use a nail file. A nail file won't cut your skin. So use a nail file just to shape the nail then. And if you cut it down too low, you might end up with an infected toe. And again, infections don't heal very well. So make sure your feet are in really good condition. We also check in between your toes, because in between your toes, you can get fungal infections, simply because you've got high sugar levels. So athlete's foot is more common in people with diabetes. So again, athlete's foot looks like a white plaque in between the toes. That would need antifungal cream or antifungal powder. Some people like to, when they've washed and dried their feet, to put just a little bit of antifungal powder just in between. Now, we also say, get in tune with your feminine side. Moisturize your feet every day. Wash your feet well. Dry them well, especially in between the toes. We don't want that in between your toes are warm, dark, and moist. That's perfect for fungal infections to occur. So make sure when you wash your feet, dry them really well, moisturize around the foot, but do not moisturize in between unless it's an antifungal cream. But you can put an antifungal powder in between, but just don't put regular cream in between. Okay. We also check the pulses of your feet. So the pulse just inside of your ankle and the pulse on the top of your foot, we also check those to make sure that you've got circulation going. And also, we want to know that if you do have, some people have swollen ankles and we literally can't feel the pulses. If that's the case, we'll just check that your feet are warm and well perfused. That means pink, that you've got, good circulation. So it's very important. Your feet may be the furthest away from you, but they are a really important part of your body, because that's what's going to help prevent things like having neuropathy and to prevent having amputations of the toe. Some people have amputated toes, some people have ulcers because of either missing a foot that wasn't in the best condition, or simply because there's nerve damage, or simply because there's cardiovascular damage, artery and vein damage. Okay. So the tablets there. So the other thing that we ask about when you come for your review, we check what tablets, if you're on tablets, because not all diabetics take tablets. You may be diet controlled, which is brilliant. But if you are taking medication, it's no good having it on the list and you're not literally taking it. We do get people that come, yes, I've got this. But when I check on the list, I'll say, well, you've not actually requested that one since May last year. So I know you're not taking it. So the tablets are prescribed for a reason. It's to support you in managing your condition. So, if there's any tablet that upsets your stomach, for example, metformin can upset your stomach, give you gas, give you diarrhea in some people. If that's the case, let the GP know, because there's a different type of metformin that you can take. And if that doesn't work for you either, there are other medications. There's lots of medications to treat diabetes. So don't suffer in silence. Let us know about it. And do let us know if there's a problem and we can help you. Okay. Oops. Here we go. Oh, yes. So this is just saying as well that it's not all about what we want you to do or anything like that. It's about talking. It's about talking with you. Now, for some reason, here we go. So any queries, anything that you're worried about, it's about you. We're here to help you. So if you have any questions, bring them to us. It could be, I don't know, you can't work out when best to take your tablets, for example. Whatever it is, if it's important to you, it's important to us. So let us know what your queries are. Some people, when they hear that they have diabetes, do go into a state of just depression, just having a low mood, but it is not, don't see it as a death sentence. It is manageable. We can manage it and we can help you to manage it the best possible. But if you do need help with your mental health, let us know about it and we can refer you for counselling. Diabetes is a lifestyle, so having any condition at all, this is your life and we want to help you make the best of it. Okay, so we're talking about lifestyle in general. Diet is probably one of the main things that we want to talk about. So food choices. So in general, and not just because anybody has diabetes, but any health condition, we'd say in general, have less sugar, have less salt, have less fat, increase your fibre, increase fruit and vegetables. If you drink alcohol, reduce alcohol. If anybody smokes, reduce or stop smoking. All those things are good for general health. So food choices is one thing, but portion control is another. So if everybody puts a fist up or looks at your fist, that is 1 portion, for example, of carbohydrates. It's 1 portion of fruit. It's 1 portion of pasta. So in general, that is 1 portion. So no matter how big you are, if you're overweight, your fist is still 1 portion that should be for you. Okay, so on a plate, so 1 portion of rice, for example, is that. Now, I confess, on a Sunday, my plate might have 2 or 3 portions of rice, but I have to be aware that my body can only break down 1 portion per time of each of those things. So, for example, if I was having an orange, I want to make sure that orange is no bigger than 1 portion. And when we talk about fruit and vegetables, we talk about 5 a day, or some even talk about 10 a day. It's okay having 5 a day, but not all at once. 1 portion. Spread out the next portion later in the day and later in the day. Don't have more than 1 portion at a time of any one thing. So yes, grapes are good, but not a punnet of grapes. Not half a punnet of grapes, 1 portion of grapes should be in your hand, okay? And have regular meals as well. Dr. Carol was mentioning before that when sugar is broken down, some of it is stored in the liver, and that's there for when it's needed. So when anybody's, for example, on fasting or missing meals, the liver will send out some parts of glucose just to keep your body and your organs with enough energy. So if you don't have enough energy, your body compensates for that. Now, sometimes people come to us and they'll say, but I don't eat. I don't eat except once a day. Well, that means that twice a day you didn't eat, which means that twice a day your sugar was being provided for you by the liver. And that's why people's blood sugar can still be raised, even though they're not eating very regularly. So it's better to eat little and often. But if you are on fasting, just be careful. And yes, your body will produce sugar, but when somebody has diabetes, you need to be on fasting carefully because it depends on what medication you're on or if you're on insulin. So it's wise to speak to somebody about that for your individual person. Activity. So we talk about exercise, and when people come to me, they'll say, oh, but I'm on a walking stick, I can't exercise. Well, you can be active. You can be active. You can do things in a chair. You can raise your arms above your head. So increase your activity. If you can move, even if you're sitting, and you can move your feet out and back in, and back out and back in, and twist and turn. There's something, unless you're bedbound, and even if you're bedbound, hopefully somebody will be there to lift your hand for you, you know, and to move you. You want to keep active. And that goes into weight management. So the more active you are, then not the more easy, but you will be helping to manage your weight, because as I said before, body mass index is really important to keep down if you can. And if anybody does have issues with weight and would like support, there are loads of departments that we can refer you to for weight management. So, you know, don't feel any shame, don't feel no way about saying, I'm overweight and I need help. You know, we're here to help you and to refer you to the right places. And alcohol and smoking, alcohol converts into sugar. So when people are drinking a lot of alcohol, then that converts into sugar, and that's not great because of pre-diabetes or even if you're diabetic. And smoking as well. That can damage the nerves. So again, people that do smoke can have problems with not being able to feel their fingertips and their toes because of the nerve damage as well. Medication. So I spoke briefly about that before, but Sister Carol mentioned sick day rules. Now, sick day rules are where if somebody is unwell with either fever, vomiting, diarrhea, sweating, shaking, so any of those things where you're losing fluid in particular, then some medication may be more harmful to take than to take, but it's only some medication. So I don't know what medication you're taking. However, in general, if you are sick with any of those symptoms that I was just mentioning, then you should stop taking metformin. You must, if you're on insulin, you must still take insulin. But there are certain other medications. Metformin is one. There's something called Ramipril, and the prils that are for high blood pressure. There are the Flozins. So if somebody's taking something called canagliflozin, or there are other Flozins, that's one of the medications that you would stop taking. But you work with that with your health professional. They will have the list of your medications and tell you which ones, if you're not well, you should stop taking. But once you're well, by about 1 to 2 days later, after feeling better, that's when you need to take those medications again. Okay. Now, if anybody is considering a pregnancy when they have diabetes, then it's classed as a high-risk pregnancy. So if you are planning a pregnancy, we advise you to have a chat with the health professional so that we can get you into a consultant care, because we do need to monitor your pregnancy really closely. And then information prescriptions. So here, once we've had a chat with you about your various results, blood results, we'll go through the blood results with you, your cholesterol, your sugar levels, your kidneys, your liver, your thyroid, your full blood count, whether you're anemic or not. We'll be able to give you equivalents of this. I don't know, can you see that? These are called information prescriptions. So it gives you information about all sorts of diabetes care. So this one's about HbA1c, that's the sugar level. This one is about cholesterol, gives you ideas and hints and tips about looking after yourself when you've got cholesterol. These two are talking about how to look after your feet, your kidneys, high blood pressure, having kidney disease itself, eating well, contraception and pregnancy, and then increasing your diabetes knowledge. So there is a lot of information out there. And I think because of social media and the internet, we are able to find out so much more information. Okay, so we would point you in the right directions. And if we can't manage, we also have diabetes specialist nurses that we can work with and send you to. So when somebody's first diagnosed with diabetes, they again automatically would be referred to the diabetes education people, and they would be able to help support you. Okay. I'm going to skip over this because Dr. Carroll did already talk about the complications of diabetes. Okay. And then just tips. When you're going to come, make sure you drink plenty of water, not coffee, not juice, but water, because that'll help to put more volume in your veins when we're taking a blood sample. Bring a sample of urine with you because we need to dip it, we need to send it off. Have a list of questions for us. Wash your feet. It'll just make it a little bit more pleasant for us when we examine your feet. And still, if possible, wear a face mask. Some people feel very uncomfortable wearing a mask and choose not to, but if you can, we do ask you. And hand, face space, we're still talking about. So just to remember, take the condition seriously. It can be damaging to have diabetes, but it is reversible. Know your numbers, get used to what your numbers are. Blood pressure, height, weight, HbA1c. Make sure that you know your numbers. Don't hesitate to ask questions. And if I don't know, I'll find somebody that does. And it can be reversible. That's one of the main things about type 2 diabetes, not type 1, but type 2 can be reversible. So we can help you work towards that. Okay. And thank you very much. I've put 3 websites there. Diabetes UK is an excellent source of information for diabetes. And you'll also find information on NHS websites as well. So by all means, either ask at your GP practice, you can Google it, or if we have time, you can ask questions now as well. Thank you very much. Thank you. Back to Brother Simon.
Praise the Lord. Thank you for that presentation, Sister Elaine. Just about time, I'm just going to check with Pastor, because we were hoping to finish at past, weren't we? So shall we give about 5 minutes for Q&A, or just leave it to email? 5 minutes, okay. Okay, so we're going to have 5 minutes for anyone with question and answer. And I do request that, because of time, do just come forward with the question and we'll address it as soon as possible. And as I said, any questions can be sorted through email. I'm sure Sister Karen and Sister Elaine would be happy to. So if there's any questions.
Very quick one from me. In terms of monitoring your own, I mean, I don't think I have diabetes, but is it a good idea for people who don't have diabetes to monitor their own diabetes, their own sort of blood sugar at home, so you're pre-warned, or aren't they accurate enough, or is it a different kind of blood test?
Can I answer that? So, God bless you, Brother Desmond. So, in general, no, you don't need to, because if you follow healthy, balanced diet, exercise advice, then you wouldn't need to. And I'm glad you mentioned that, because sometimes people come in and ask about blood sugar monitors. You don't actually need a blood sugar monitor unless you're on insulin, or unless you're on certain medications, for example, glycoside, which drops your blood sugar really fast, and we need to make sure that you are not going into a hypo. So in general, no, you wouldn't need to test your own blood sugars, but do be aware of healthy eating. There is something called, as Dr. Carroll said, pre-diabetes, which is non-diabetic hyperglycemia. That means you don't have diabetes, but you do have high blood sugars. And if that's the case, you are at risk of diabetes. And if that's the case as well, you will be having annual blood tests as well at the GP surgery. But no, healthy eating, healthy diet is the way to go, and exercise. But for testing, no, not really. It's not really recommended.
Thank you.
Can I just add that there is something that's offered on the NHS called we call it the NHS MOT. What's the proper name?
The health check. There's a 5-yearly health check. The NHS health.
Yeah, it starts at 40. So once you get to age 40, if you're worried that what if I develop diabetes and I'm not aware, once you're 40, you're eligible for this health check. And in this health check, we do things like checking your bloods for diabetes, check cholesterol. You get a full MOT. And if everything is okay, then you don't need to do it again for 5 years. But if anything is picked up, then that is when we would pick up things like your pre-diabetes, for example, and we would be monitoring you. If you do have a strong family history and you're having symptoms, then you don't have to wait until age 40. You can go along to your GP, discuss it, and get the relevant tests done. And if the diagnosis is made, then it's picked up that way. But as a whole, on the whole, you don't need to be doing your blood sugars at home if there are no symptoms and you're not like, yeah.
I've got a question. If you suffer with high blood pressure, I know the normal reading is 100/20. When do you reach danger point if you suffer with blood pressure? Or what the correct reading is supposed to be if you suffer with blood pressure?
What's the target?
Yes.
Sister Elaine?
Yes. So if somebody is diagnosed with diabetes, we want it down to 130/80 or below. If you don't have high blood pressure, then 140/90 and below is classed as normal. Anything over that, we'd want to watch you more closely. So again, that's why it's a good idea to have your own blood pressure monitor. But when you take a blood pressure, don't take it when you're watching a horror movie shouting at the kids. be quiet, be rested, and then just take it. Do it 3 times, and then once you've done it 3 times, the lowest figure is the one that is your blood pressure at rest. Yeah.
And we don't suggest that you do it every day either. Some people are monitoring it every day. When I used to be on night duty on the phones here, people would call us at 2 o'clock in the morning. I've just checked my blood pressure and it's high. What do I do? My first question is, why are you checking your blood pressure at 2 o'clock in the morning? So some people are obsessed with it and they do it every day, every 10 times. It's not necessary. If your blood pressure is well controlled, Sister Elaine mentioned once a week, even that probably it's not necessary to do it that often. If there is a problem and your GP has said to you over this period, not monitor your blood pressure every day, then but you don't need to be at it, because that in itself makes you anxious and you're more likely to get higher readings.
Can I ask a question, please?
Yes.
With the blood pressure being a diabetic, does the age group makes any difference what age you are? Does it mean that if you're elderly, is your blood pressure supposed to be exactly the same as the average person?
Do you want to answer, Sister
Yeah,
Carol?
go on. Yeah.
There is a configuration, and I can't actually remember off the top of my head what it is. But when somebody has raised blood pressure, we again, like blood sugars, we don't want it to be too low, because when the older you get, the more frail or unbalanced you can be. So if we're sort of treating you with blood pressure tablets all the time and getting your blood pressure down too low, then you're more at risk of falling over and injuring yourself. So again, it's an individual thing. So I don't think one cap fits all or every age, but that's why you need to be monitoring it in line with your GP or your health professional.
Thank you.
Yeah, generally the older we have to stick with the 140/90 as more of a word, but younger and with diabetes we'll be happier with the 130/80. But like Sister Elaine said, there is risk of falling as well. So it's a balance.
Thank you very much.
Greetings. I used to take the vitamin tablets. How does that affect diabetes? Is it a good thing to take, or should I not take it? No, because I've been diagnosed just lately, so I just want to know how vitamin tablets affect your diabetes, if it's hard to take it or not.
Okay, so may I ask what vitamin tablets you're taking?
Well, I used to take the B12 and cod liver oil.
Okay.
And, yeah.
So have you been told that your B12 level is low? Or you just...
No. I think that it seems to be all right at the moment, but I used to just take it before I got diagnosed. I used to take it. So just additional.
Okay. So the general rule of thumb is multivitamins or vitamin supplements are not generally necessary if you're eating a healthy diet. Generally speaking, there are some vitamin supplements which we know can be beneficial. For example, vitamin D. We've heard a lot about that over COVID, but even that, ideally, if you can have a blood test to know exactly whether you're deficient or you just got insufficient levels to guide you, that will be better. But things like the B12, I would prefer if you've had a blood test before you're taking vitamin B12, because you can have higher levels which can be more harmful than good. And all the other multivitamins, if you're eating healthy, you really don't need it. And what we say is that you're probably just making expensive urine, really, because your body is not gonna be doing anything with them, especially things like iron and that. Because if you don't need it, it's not beneficial. So certain things we need to be aware of, like vitamin D, because apparently that has an impact on diabetes as well because of the immunity and how the body works. And B12 is one that is worth knowing because of the neuropathy that it can cause, which could complicate diabetes neuropathy as well.
Right. All right, then, thank you.
You're welcome.
Can I just ask one more question, please?
Okay.
The last one.
Yeah, I've been on insulin for probably over 10 years. And I have the feeling that the insulin that as effective as it used to be when I first started. Should it be changed, or is there something different happening in the body?
So yes, a combination of things. It could be that more things are happening because as we age, generally with or without diabetes, our blood vessels change. They become thicker. We develop diabetes even just because we're getting older. Type 2 diabetes. So if you find that your insulin isn't as controlled, isn't as effective as it is, then the thing that should tell you that is your HbA1c. And if your GP is monitoring your HbA1c, then that should say whether the insulin needs to be changed or not. But if there is a case that the insulin needs to be changed, it can be changed because there are different insulins on the market. Some are more long-acting than others, and some, are more effective. So yes, if you feel it's not working, then yes, there's a discussion to be had with your doctor. But that would be objectively identified by your HbA1c level. That should say to your GP, things aren't 100% here. We need to do something. And if necessary, refer you to the specialists at the hospital.
Right. Thank you very much for that. Thank you.
Yeah.
Okay, so first of all, I'd just like to thank everyone. First of all, mainly the speakers, Sister Carol and Sister Elaine. And I'm sure, reading the comments, I'm sure I'll speak on behalf of everyone that you've done an excellent job at presenting and an excellent job in bringing so much information that we can take away with. Certainly there's a lot for us to take in. Sometimes it just takes that time just to sit back and absorb it, and you may have further questions. It happens all the time. So, I give thanks for all of you that connected on our first webinar with Bethel Pneuma Tabernacle